I would like to introduce our speaker. Brian Chicoine, MD, is the Medical Director of the Advocate Medical Group Adult Down Syndrome Centre in Park Ridge, Illinois. He is on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. He received his medical degree from Loyola University of Chicago Stritch School of Medicine and completed his family medicine residency at Lutheran General Hospital. In 1992, Dr. Chicoine co-founded the Adult Down Syndrome Centre, which has served and documented the health and psychosocial needs of over 6,000 adolescent and adults with Down syndrome since its inception. Dr. Chicoine has provided medical care for adults with intellectual disabilities for over 35 years and has presented and written extensively on caring for adults with Down syndrome. I'll hand you over to Dr. Chicoine.
Thank you very much, and so glad to be here with you this evening here. Tomorrow morning there, it's always amazing. I just want to make sure I'm on the right day, much less the right time when I'm presenting to Australia. So I got here on the right day and time. And I love the tradition that you have of recognizing Native or Indigenous people. That's a lovely tradition. I appreciate that very much. So as was mentioned, I'm Brian Chicoine, the Medical Director of the Advocate Medical Group Adult Down Syndrome Center, and we're going to talk about aging this evening. This is our center. We're located, we're a suburb of Chicago. We're about 25 miles northwest of downtown Chicago, about 7 miles northeast of O'Hare Airport, the big Chicago airport. And we are about 15,000 kilometers from Sydney. So a little bit of a distance from you. And I hope the weather holds out. I mean, I hope the electricity holds out here. We are having a thunderstorm at the moment. So hopefully that won't be a problem. But fortunately, the wires are underground here and we don't lose power very often. Like a Chicago spring, today it's about 12 degrees Celsius with pouring rain, and 3 or 4 days ago it was 30 degrees Celsius with hot sun. So you never know what you're going to get in Chicago in the springtime. In fact, in any given day, it can be all those things. So summer is coming. Again, I'm going to talk about aging, and we have I'm going to talk for about an hour and 15 minutes or so and leave about 15 minutes for questions. But certainly even in that time, we can't really address all the issues. So I'm going to just point out that we have an online resource library, which we are in the process of updating. So hopefully by early next year, we will have that revamped. But for now, there's lots of information, over almost 600 pieces of information on our resource library, and a lot of it on aging and the health issues associated with aging. And so feel welcome to connect to that if you want additional information, but I'll really try to address the main topics here tonight. So again, this is really an education opportunity. It's certainly not meant to replace the care you receive or can receive from your health professionals. So, certainly feel welcome to share with health professionals, but really not meant to take their place. So we're going to focus on how aging in people with Down syndrome is similar, but also how it may be different to people without Down syndrome. Some common conditions associated with aging, and then in general, supporting adults with Down syndrome who are aging. So as no surprise to this audience, I'm sure, today people with Down syndrome are living longer and healthier than any time in the past. And this is US data. And I use these 3 years because 1907 was the year that my great uncle Leo was born, and he had Down syndrome, although that's not what they called it at the time. And his life expectancy was only 9. Interestingly, he lived to be almost 40, which makes it pretty clear he did not have congenital heart disease. He was not born with heart problems. Now that history is not available, family history is not available, but it would have been very, very unusual for him to live really much beyond a year or two in those days with severe heart, with significant heart disease. And then in 1984, when I graduated from medical school, the life expectancy was about 28. And then in the late 70s, early 80s, the opportunity and the ability to treat congenital heart disease with surgery came about. And that made a dramatic change in the life expectancy of people with Down syndrome. Um, so since I graduated from medical school, the life expectancy has really more than doubled. And I don't take credit for that. It really, again, a lot of that has to do with good general health care, which hopefully we provide, but also really a big chunk of that is to the ability to treat congenital heart disease, which the life expectancy, again, as I mentioned, was very short in days in the past. Um, but again, this is data from higher income nations like the U.S. and Australia, and is in the United States is from the white or Caucasian population, and the numbers for non-whites is a little lower than these numbers. Now, unfortunately, uh, that curve is not continuing to go up. That has leveled off now, and a lot of that seems to be related to Alzheimer's disease, which we will talk about today, of course. But that really does seem to be limiting a further increase in life expectancy. So not only are people living longer, then it's not surprising that adults with Down syndrome, there are more adults with Down syndrome than ever before. So we'll show Australia data here in just a second, but this is US data. And then if you look at since 1950, the population of people with Down syndrome overall increased 4 times. And the adults with Down syndrome in the United States during that time increased almost 9 times. And that's while the rest of the US adult population only doubled. So again, it's a very significant, even a comparison increase to the number of people with Down syndrome compared to people without Down syndrome and the big changes. And then in Australia, since 1950, there's been about a 4 to 5 times increase in the people with Down syndrome, and adults about 10 times. And again, during that same period of time, the Australian population as a whole increased 3 times. So very significant increase in people with Down syndrome, and particularly adults with Down syndrome in Australia in the last last 2 or 3 or 4 generations. So we have a unique opportunity to really look at how can we help these individuals be healthier as they age, and what are the issues with the health conditions of aging that we need to address. I mean, on a personal note, there really aren't too many healthcare professionals who had the opportunity to have their patient population double their life expectancy during the course of their career. I don't take credit for it, but it's been a very interesting time to really learn a lot about how we can help this population promote their own health. So what are some of the similarities in aging? And certainly those of us that are closer to that aging population, personally, certainly becoming more set in one's ways is not unusual. I remember when our grandparents lived with me, my grandparents lived with me when we were kids, and I was really amazed at how set in their ways they became. And that certainly happens with a lot of folks with Down syndrome as well. They're slowing down physically and certainly sometimes mentally as well. And again, those are not unique to either population. And then different activity preferences. And so oftentimes I hear, they're concerned, he doesn't like to play baseball anymore. I say, well, he's 45 years old. And, a lot of us as we get to, that age aren't interested in baseball. Maybe taking a walk or a bike ride would be more the speed. And that would not be unexpected in folks with Down syndrome either. For many years I've heard, people with Down syndrome, even adults, even when they're 50 and older, described as kids. And not only is that not correct, it's also sort of really not appreciating that these individuals, like the rest of us, will get older, mature, develop new interests, and have things they want to do and things they don't want to do, not unlike the rest of us. So those are very clearly similarities. There are clearly some differences as well. People with Down syndrome do seem to have an earlier aging process, so it does seem to be more rapid aging. A lot of times, again, it's just a rough observation, but for a lot of our individuals that we serve, before they get to 35, they often look younger than their chronological age. But as they begin to get beyond age 35, and again, those are just rough. That's just rough numbers. But as people get beyond age 35-ish, the aging seems to pick up pace. And so, as people get out of 35 and 40, we really begin to think of them as 5, 10, 15, 20 years older than their chronological age as they get out into their 40s and 50s. So there does seem to be an earlier aging process. And another thing that's different for many of our folks is that as they go through life, they start living in some sort of residential or supported living situation, which is different than but much of the other younger population in the non-Down syndrome community. And then there are some health conditions which are different, which we'll talk about here in just a second over the next few slides. And then certainly, who is providing the support or the care for these individuals. And when we talk about Alzheimer's disease, we'll talk a little bit about, Down syndrome is a very unique population in that from an Alzheimer's standpoint, for example, it's the parents often providing the care for a son and daughter rather than a son or daughter providing the care for an adult, their parents with Alzheimer's. So it really is sort of a unique situation in people with Down syndrome on who is providing their assistance compared to the rest of us. So let's talk some about some common conditions and as well as some uncommon conditions in people with Down syndrome. And again, this won't be a complete list. We're going to just highlight some different areas, and then again, we can leave time for questions, but we have a whole lot more information on our webpage. So what are some of the conditions that are more common? So cataracts are more common, and they do tend to occur at a younger age. And a cataract occurs when the lens of the eye becomes clouded and makes it obviously difficult to see. Oftentimes it's monitored until it affects vision. Really, the only treatment for cataracts at this point is surgery. And for a number of our individuals that we have served who ended up with cataract surgery, they did require general anesthesia to have it done, where many people without Down syndrome do not require that. So it does put a little different wrinkle in the process. And then some of the other challenges some of our individuals have are the eye drops that are required after surgery. And for some people that can be difficult. But otherwise, we've had many patients successfully undergo cataract surgery. And it can be so life-changing. And I was just reading an article a couple of days ago on how difficult losing a sense, vision or hearing can be for individuals with Down syndrome, and how challenging that can be. And that certainly supports what we have seen over the many years, that how challenging that can be. Several years ago, a gentleman he lived in a residential facility, and the staff brought him in. And I had seen him 2 years before, and he seemed to be doing fine. He did an exam, his eyes looked normal. But in the subsequent 2 years, he had started to decline in skills, and the staff was convinced he had Alzheimer's disease. And I looked at his eyes, and as happens also in folks with Down syndrome, not only do they occur earlier, but sometimes they develop more rapidly. And so he had, in that 2 years' time, had developed very dense cataracts. And his problem was that not that he had dementia or Alzheimer's disease, he just couldn't see well. And so his decline in skills was treated by an ophthalmologist who removed his cataracts, and he returned to his baseline functioning. So again, we talk a lot about decline in skills as we go through aging, and very important to make sure we're always looking for potential causes that, like cataracts, that are very reversible, that we want to make sure we're addressing. And then hearing loss, another loss of sense. And this really is a problem for any of us as we get older, that hearing loss, and it does appear to probably occur at a younger age in people with Down syndrome, probably is more common. At least in our experience, that definitely occurs at a younger age. But one of the challenges, like many of us, we lose our hearing, and we just have a hard time explaining that, or even understanding that our hearing is declining. And so oftentimes it's noted by other people more than it's noted by ourselves, and this is true for people with Down syndrome as well. And sometimes people will present with a behavior change, or a loss of skills. And so certainly we have a lot of individuals that get hearing aids and do very well with it. So very important, hearing very important. And we know from, again, we'll talk about Alzheimer's here a little later, but we know from literature, and that it not replicated in people with Down syndrome, but in the non-Down syndrome population, hearing loss reduces socialization, social interaction, and the reduced social interaction is actually a risk factor for Alzheimer's disease. So hearing loss can be so important to make sure that we're addressing that. And if it's more common, we definitely want to make sure we're addressing that. A couple quick stories. Joe comes in, and the family is concerned that he has developed Alzheimer's disease because he's no longer following directions. I examined Joe and find that his ears are full of wax, which is a very common problem with people with Down syndrome. And I remove the wax and I cure his Alzheimer's disease. There is nothing more satisfying than a quick Alzheimer's cure with a little syringe and some warm water. So that's obviously a facetious story, but it's not so facetious because it happens all the time. I see that quite a bit where people seem to be losing skills and not and it's just really earwax. Another common thing is let's call her Lisa is developing obstinate behavior, and she is not following directions. She is in fact just doing the opposite of what she's being asked to do. Family will ask her to do such and such, and she'll go do something completely different. And the family's, this is not Lisa's typical behavior. And as part of the evaluation, we sent her for an audiology evaluation and find that she has high-pitched hearing loss, which we tend to lose the high-pitched sounds before the lower-pitched sounds, and as far as hearing. And when you lose the high-pitched sounds, often it's the consonants that we have more difficulty with. And so she is hearing, but she's not understanding because she's not getting all the sounds. And so as with many people with Down syndrome, Lisa really has a desire to do what she is asked. And so she's going to go gung-ho. Unfortunately, she's hearing it incorrectly, so she's going gung-ho in the wrong direction from what people have asked her. And as many people with Down syndrome and the rest of us, she has a real desire to please others. And so she is really going full gusto, but in the wrong direction, or not the direction she's not been asked. So this was, again, misinterpreted as a behavioral issue. And again, it was a hearing problem. And so addressing her hearing problem really solved that issue. And so again, that's also a very, very common story. And none of these stories are one person, and they're made up of a lot of different people, because almost all of these things have happened many, many times in our practice. Another thing is many of us will develop as we get older is osteoarthritis, the wear and tear arthritis, knees and hips and our common backs, common places. Is this more common in people with Down syndrome? It's not clear, but I think it probably is. And one of the reasons it may be more common is because, as you probably know, people with Down syndrome tend to have lax or looser joints, and looser joints tend to take a little more beating as we go through life. And so that may change, cause there to be more wear and tear and more osteoarthritis. Probably does also for the same reason occur at a younger age. Probably is underreported. And some of that may be that people with Down syndrome often don't report pain in the same way that others do. So they may be experiencing the pain, but they may not be reporting it, or they may have a difficult time localizing it. So they may be having some significant discomfort and just not reporting it. So in our practice, we see that it often presents more as a functional change more than pain. So where you and I might complain of knee pain, it really doesn't become clear that the individual with Down syndrome has significant arthritis until the knee is no longer functioning as well and his or her gait changes. So that would be a common thing in our practice. Once again, we've had a number of people very successfully undergo joint replacement, joint injections, whatever, all the different treatments. And so certainly those are not indications to, having Down syndrome is not an indication not to do those procedures, because people with Down syndrome, in our experience, have responded pretty well to those. But again, oftentimes it may present in a different way. So, someone takes a bus to go to work and is now refusing to get on the bus. And so, again, people will misinterpret that as, he or she's developing a behavior issue, or who knows what else, they're looking at, and not clear why that's happening. But getting on a bus sometimes takes a big step. And now this person has significant arthritis in her knee or her hip, and she's not able to make that big step. And so she's refusing to get on just because it's so functionally difficult for her. So again, hear this theme over and over as whenever I talk about older, aging people with Down syndrome, or any people with Down syndrome for that matter, that oftentimes physical problems will present as behavioral changes, and we really have to go looking for those underlying physical causes. And arthritis certainly is a significant issue. Another thing that we're concerned about for all of us as we get older is osteoporosis, or thinning of the bones. one of the questions is it more common? And really the data is uncertain. And some of that comes from the older data does indicate that people with Down syndrome had more low bone density on DEXA scans, so the bone density scans. But now there's really the accuracy of DEXA scans in people with Down syndrome or any shorter people has been called into question. So we really a little uncertain as whether this is more common or less common or the same. The other thing we don't really have are good data on fracture risk. So certainly one of the real concerns about osteoporosis would be, are people developing fractures? Are they breaking bones more? And there really is very limited data for people with Down syndrome with regards to fractures. And so we really don't have a good picture of the osteoporosis in people with Down syndrome. The other thing is that the medications that we frequently use for osteoporosis probably don't work as well in people with Down syndrome. And some of that has to do with the way the bone is overturned. The bone is not a static tissue. It's constantly being turned over. Calcium is taken out, calcium is put in, restructuring. All this is happening on a regular basis, and that function is different in people with Down syndrome. And so the medications that impact that metabolism of the bone, because that metabolism is different, is causes those medications not to work in the same way. So again, the medications may not work as well as people with Down syndrome. The other challenge we've had when I was still prescribing a lot of those medications, we had a significant number of side effects with ulcers, the stomach or the esophagus, and as a complication of those medications. So, so there's that we have to deal with as well. I'm part of the team that wrote the global healthcare guidelines for adults, and which we'll discuss more in a moment. And when we looked at osteoporosis, ended up making a recommendation that we really could not recommend for or against DEXA scans and treating osteoporosis, because we just don't have the data at this point that tells us that it is or is not the right thing to do. And then certainly for women with Down syndrome, and for all women, as they get older, menopause is an issue. And this seems to occur at a slightly younger age in women with Down syndrome. In general, the treatment options are the same for women with and without Down syndrome. Certainly, one of the other things to think about, again, is people with Down syndrome get older, and we certainly, again, we'll talk about Alzheimer's in a second here, but, we talk about Alzheimer's disease, but also, many women will complain of some memory issues, some mood changes, and even a less sense of well-being with menopause. And so really want to be thinking about, should we be providing medications or other treatments for menopause? And certainly, regular exercise, healthy diet, obviously all recommended, but then should we be offering other things as well that might help with menopause? Dr. Graham, who works in our office, was the primary author for a women's health guide that's published by put out by the National Down Syndrome Society here in the States. And that's available free online at the National Down Syndrome Society site. So if you'd like to learn more about that, I would encourage you to take a look at Dr. Graham's health guide there. I should also add, even during the course of my career, earlier in my career, we were full gung-ho on treating women with menopause with hormones and other medications, and that really sort of fell out of favor based on a few studies that showed some negative complications from those. And now people are beginning to go back and look at that, and in some situations, those medications might be the right thing to do to ameliorate symptoms. And so again, that's kind of coming around full circle, but with some caveats on who or who may not be appropriate to treat with those medications. So we certainly talked about some things that are more common. I also want to talk about some things that are less common. And it's important to understand these as well. So we know that, excuse me, solid tumors are less common in people with Down syndrome, and that would include things like breast cancer and colon cancer. And high blood pressure is significantly less common. We see very rare to see high blood pressure in our patients. Atherosclerosis, which causes the hardening of the arteries or the plaques in our arteries, in our heart, and in our brain that cause myocardial infarctions or strokes. That is much less common in people with Down syndrome. Type 2 diabetes, that's a little trickier because people with Down syndrome have a higher rate of being overweight and obese. We would expect that type 2 diabetes, which is the diabetes that we tend to get when we're older, and again, associated with being oftentimes being obese or overweight. So despite obesity and overweight being more common, in our study, type 2 diabetes was less common in people with Down syndrome. I can't really explain that, but finding is what it is. Although in a study in the UK, they found that from late childhood to early adulthood, type 2 diabetes was more common. So at least in some age range, it was more common. We did not break ours down by age. So it's an interesting topic that needs ongoing research to really sort through that. And in fact, it does turn out that people with Down syndrome have less type 2 diabetes despite being more obese. Certainly we'd want to know why that is as well, because that certainly could benefit others as well. And then an article came out recently that suggests that people with Down syndrome are less susceptible to viral infections, which is kind of interesting. I can tell you certainly that was not the case during the COVID pandemic. We had both in our practice and in several other studies that people with Down syndrome had more COVID infections than others. And so I think that piece of information, I think we still need to explore more and see what that's about. And these are the global guidelines I mentioned, and they were published in October of 2020. There's an article in JAMA, which is the Journal of American Medical Association, and then there's versions for families, including several checklists, and those are available. The family checklist and family article and the checklist and whatnot are available free on the global website, which the link, and you'll get these slides if you haven't already, and it's free on their website. And again, we're doing what I call round 2. We're working on that, and in round 2 we will be addressing the solid tumors and some other things. And so certainly I'm very interested in some of these cancers that are less common. And does it make sense to do the same screening for someone with Down syndrome does with someone else, for someone else, if the cancer is much less common than in other people? And so more to come on that. But those are certainly things to think about as we're screening people. In fact, we're working on, there's a group there in Australia, and then a group here in the States, some from Denver and a couple of us from our clinic, who are looking at pap smears and cervical cancer, which also does seem to be less common in women with Down syndrome than in the non-Down syndrome population. So again, so what does that mean for screening? What does that mean, for treatments, et cetera? But more to come on that. We don't have an answer for those yet. So as I suggested, we're gonna talk about Alzheimer's disease, which again, we talked about is more common in people with Down syndrome. As you probably know, Alzheimer's disease is a progressive neurological condition. It affects the brain, and it's a type of dementia. People often ask, what's the difference between dementia and Alzheimer's disease? So dementia is an overriding category. So I like to think of it as cars. Cars would be like dementia, and then Alzheimer's disease would be like Chevrolet, or and then there's other types of dementia that would be the other types of cars. And so there's the umbrella category, which is the dementia, and then there's these other types. Now, it's thought that Alzheimer's disease is the most common type in people with Down syndrome. It probably is the most common type for all of us, but there are other types of dementia that that can cause people to have cognitive decline, particularly as we get older. And Alzheimer's disease, when you look at the brain tissue of a person with Alzheimer's disease, with or without Down syndrome, they have what they call plaques and tangles, which are microscopic changes of the brain that are consistent with Alzheimer's disease. Now, unfortunately, by age 40, nearly all people with Down syndrome have the brain pathology of Alzheimer's disease. And so clearly much more common. And so why is that? So the amyloid precursor protein, also called APP, is a gene. It's coded for by a gene on the 21st chromosome, and because people with Down syndrome have an extra 21st chromosome, they have more of a load, if you will, of this amyloid precursor protein, and that's really thought to be a major contributing factor to Alzheimer's disease in people with Down syndrome. In fact, there are a handful of individuals that have been looked at who have don't have a complete 21st chromosome, extra 21st chromosomes. So they have 2 plus 21st chromosomes, not 3. And in those individuals that are missing this part of the 21st chromosome that has the APP gene, they do not seem to have this increased risk for Alzheimer's disease. So that would certainly be quite supportive that this APP gene and protein has an implication with regards to this higher rate of Alzheimer's disease in people with Down syndrome. But there may well be more to it than that. It's now people are really looking at the chronic inflammatory state that seems to be part of having Down syndrome. And we certainly know that autoimmune diseases are more common, and that seems to be potentially a contributing to this factor around the inflammation. There is a number of people that have written suggesting that Down syndrome is an interferonopathy. Interferon is part of the immune system and part of causes inflammation. In a good way to help fight infections, but in a bad way can cause this chronic inflammation that has a number of negative implications for our brain and other organs. So that people are looking at, may that be contributing to this situation? And then certainly metabolic abnormalities. People are really looking at, are there metabolic abnormalities that contribute to Alzheimer's disease? And certainly some people have called Alzheimer's type 3 diabetes, which really is not a term, not a recognized term, but it speaks to the possibility that metabolic issues contribute to Alzheimer's disease. So really more studies needed on that, but we may ultimately find that this is going to be a multifaceted cause as well as a multifaceted treatment needed with regards to Alzheimer's disease. But to go back to the fact that I said that nearly all people with Down syndrome have brain pathology by 40, symptoms of Alzheimer's disease, however, are uncommon before 40. So these changes in the brain are developing long before any symptoms occur, years. And that's true for anybody, any of us, that if we develop Alzheimer's disease, those changes in the brain have been going on for some time. At some point, it has to reach a certain level or affect certain areas to a degree enough that it actually begins to cause symptoms. And that's true for people with Down syndrome as well. So how often does it occur? So estimates vary. And some studies suggest that 55% of those between the ages of 50 to 59 will develop Alzheimer's disease. Some studies suggest greater than 75% in those ages 60 and older. Some data now suggest that 90% of people with Down syndrome will develop Alzheimer's disease at some point in their lifetime. And so obviously a very significant problem. The average age of diagnosis is in the mid 50s, and the average age of death is in the late 50s to early 60s. So the decline probably, just on average, if you look at those numbers, the decline is over about 5 years to death. And that's probably a little less than, is less than the rest of the population. Although, again, I think that we need more study. That I think sometimes the earlier symptoms of Alzheimer's disease are not appreciated in people with Down syndrome, so that the onset may be earlier than some individuals. Average rate of onset of symptoms to death and the rest of the population 9 to 10 years, thought to be about 9 to 10 years or so. So again, this may be less than in people with Down syndrome. What are the symptoms? Excuse me, lots of pollen in the air here in Chicago. I apologize. What are the symptoms? So we know a lot of people with Down syndrome talk to themselves, and so sometimes we'll see these behavioral changes are initial presenting symptoms or psychological symptoms or changes are the earliest symptoms. So we might see someone start talking more to themselves or start talking less to themselves or have less ability to decipher where it's okay to talk to yourself and maybe not talk to yourself in other situations. So they may lose some of that discrimination. We know a lot of people with Down syndrome tend to have a tendency to adhere to routines. And that's a common thing throughout life for many individuals with Down syndrome. And so they may have difficulty continuing to adhere to the routines, or they may adhere to the routines more. They become very locked in and stuck on things. There may be other psychological changes, depression or anxiety. And these psychological behavioral changes are often thought to be the earliest symptoms in most people, although not all people. But the very common early symptoms. Certainly, just like the rest of us, memory impairment, a loss of previously mastered skills. Now, it's important again, when we're looking at neuropsychological testing, which we'll talk about here in a second, it's important to realize that, if you're using tests that are used for everyone else, and you ask, can the person, do X, Y, or Z, and the answer is no, well, then you must have Alzheimer's. That obviously doesn't hold true if the person could never do X, Y, or Z. So you really have to look at what are the skills that they had, and then what are the skills that they've lost, and that's an important thing to remember as we're assessing this. Certainly, ultimately, as this progresses, incontinence is a common feature. Weight loss. There was a study done in Wisconsin, University of Wisconsin, a few years ago that suggested weight loss. Some individuals that go on to develop Alzheimer's disease may start as early as the mid-30s, and not a lot of weight. They were talking about half a kilogram a year, but again, sort of seeing that this is perhaps an early symptom, and we know that weight loss is not an uncommon symptom in people with who develop Alzheimer's disease who don't have Down syndrome as well. So weight loss can be an earlier finding. Seizures occur at a much higher rate in people with Down syndrome who develop Alzheimer's disease than in people without Down syndrome who develop Alzheimer's disease. So in the non-Down syndrome population, it may be 2 to 25%, broad range depending on what study you read. But in people with Down syndrome, it may be as high as 50 to 85%. So it's a very much more common in people with Down syndrome who develop Alzheimer's disease than those who don't have Down syndrome. And then an unsteady gait is very common, and that can become progressive as the disease progresses. One thing I've noticed is that a lot of people seem to become unsteady. They have a sense of being unsteady, and so they have a fear of walking, and so they stop walking before they actually can't walk. And so, is there something we can do at that point with some physical therapy or something to help them be more confident in their walking, to keep them ambulatory as long as possible? And then swallowing difficulties are very common, and ultimately for many of our individuals that we see with Alzheimer's disease, it becomes what I call the terminal event. As people develop swallowing difficulties and start to have difficulty aspirating, developing pneumonias because their oral secretions or their food and drink are ending up in their lungs instead of going down the esophagus, and so that people develop pneumonia, and that unfortunately is for many of the individuals we see is what causes their passing. As far as a screening tool, the National Task Group here in the States has a tool called the EDSD, the Early Detection Screen for Dementia. It's about a 6 or 7 page screening tool, and it's we talked about the global healthcare guidelines, and in the guidelines we recommended about age 40 considering using some tool to start to screen to see if there's noticing any decline, and also to get a baseline. Some people suggest maybe starting in 35, but at some point in 35 to 40 range, start to begin to think about screening, to begin to look for some changes. And this is a nice tool to do so. A little lengthy, but very doable at home, and things that you can do to start to begin to look for any changes. And it is important, and we're going to talk next about as people, if you do notice that there's some changes, really important to look for other causes as well, and not just attribute everything to Alzheimer's. And that's part of how you make the diagnosis. So, when we're making the diagnosis, want to do a good history and physical exam, do some testing. We talked a little bit about neuropsych testing. We'll talk more about that in a second, and then possibly some imaging of the brain. So when we're doing the history and physical exam, we really want to rule out a lot of other causes. Now, certainly you would not expect autism spectrum disorder to develop in an adult, but sometimes it's been undiagnosed, and there's a stressor, and person develops some complications, symptoms that were related to his autism spectrum disorder that were not previously appreciated. And so, again, I would not expect that to be a clear indication of Alzheimer's disease, but again, things we want to make sure we're looking for to rule out other causes for that decline. Down syndrome regression disorder in younger individuals, medication side effects, sleep apnea, vitamin deficiencies, thyroid conditions. It's a very lengthy list of things we want to make sure we're assessing for to look to see, is there another possible cause for this decline? Psychological issues, physical response to psychological changes, etc. So there's a thing called diagnostic overshadowing, and what diagnostic overshadowing is where we look at it really started in the intellectual disability world, and we're, no matter what was going on, the healthcare team blamed it on the Down syndrome, for example, or the other intellectual disabilities. So, the person is developing this symptom. Well, that's just Down syndrome. Person's developed that symptom. Well, that's just their intellectual disability, and that's clearly not correct, because we really want to make sure, just throughout their life, we want to make sure we're looking for other causes for these changes. But in Alzheimer's, in folks with Down syndrome, similarly with Alzheimer's disease, so it's very common for someone to present with a decline in skills, and instead of looking at the hearing and the vision and the thyroid and the blood sugar and all those things we talked about, they just assume it's Alzheimer's disease. So that would be another way that people with Down syndrome have diagnostic overshadowing, where everything is blamed on Alzheimer's disease. And I can tell you, I've gotten calls really from all over the world. My 19-year-old's been diagnosed with Alzheimer's disease. I've learned never to say never in medicine, because the first time you get cocky, you'll have the one case. But I would say that's very close to a never, as you can get. So again, we really want to go looking for those other causes. And typically in a 19-year-old, that's probably very likely to be Down syndrome regression disorder, in what they're describing. So again, we really want to make sure we're looking for other causes. So we want to look for that pattern of decline, and then look for these other causes to make sure there's not another explanation for this decline. And then we certainly want to do some testing as part of that evaluation for those causes, in addition to good history and physical. And we want to look at some blood work, and perhaps a sleep study. We know sleep apnea is much more common in people with Down syndrome. It can certainly cause people to lose skills. And so we want to go looking for those things. And then there may be, depending on the history and physical, there may be all sorts of other tests that you might want to consider based on the findings and what the person is complaining of. And then, as I mentioned, neuropsych testing. Again, the standard neuropsych testing that's done for people without intellectual disabilities really is not correct or not accurate in people with intellectual disabilities. So there are some tests that are specifically designed for people with intellectual disability, and some actually for people with Down syndrome, which would really be much better used than what you might use for me or for you. But it's not always easy to find a neuropsychologist who's proficient in testing using these tests. So again, that's another issue as well, that a limitation that we have to sort through. And then we might consider imaging, an MRI or a CT. I can tell you at this time in history, it's rare that we find anything on the MRI or CT that really would change our management of someone we suspect has Alzheimer's disease. That is going to change as the new medications come out and become available. And we'll talk about that in a second. So at this point, we don't always do an imaging to assess the brain based on what the findings are. One of the challenges we have is that many people with Down syndrome, to get a really good MRI, they need some significant sedation or even anesthesia. And we do know that as people with Down syndrome get older, particularly as they develop Alzheimer's disease, sometimes anesthesia can be sort of scrambling for their brain. It can make them more confused. And so we really have to weigh the benefits and the risks of doing that imaging, particularly if it needs anesthesia to get it done. So here would be a common example. A 49-year-old man with Down syndrome presents with a seizure, and he had no prior history. As we talk to them, and we note that the family over the last few years has noted that he has some personality change. He's less empathetic. He's always had, again, what we call the groove, this tendency towards sameness or repetition, but he seems to be losing that. He's less groovy, if you will. He's the things that he used to do pretty routinely, he's no longer doing. He's not remembering family members' birthdays. He used to send every year every family member a birthday card a few days before their birthday, so that it would arrive promptly on their birthday. But now he's forgetting to do that. And then this is a common observation as well, not necessarily by the siblings, but just for the sake of this story, we'll tell it's the siblings report that his parents have been doing more for him, tasks that he could previously do independently. So oftentimes I'll ask, are there any skills that he's losing? And the answer will be no. As you dig a little deeper, someone else is doing some of those things for that individual that he or she could previously do for themselves. So again, really trying to look to see, is there something going on that is clear that the person is not able to do as much for themselves. So again, in this case, we would do an extensive workup, as we talked about. No other cause was found, and he continued to decline. And clearly, this was seizures related to Alzheimer's disease, and then treated that appropriately. So as people, when they develop Alzheimer's disease, certainly the rate of decline varies from person to person. And the rate of decline varies over time. So at times there seems to be some plateaus, sometimes there'll be sudden drops, sometimes it'll be slow, sometimes it'll be faster. But really it varies per person, by person to person, but also over time. Now, I would have, in the past, I would have said that the rate of decline seems to be much faster in people that have less cognitive ability to start with, although a study came out a few years ago that said that that's not the case. And so that didn't quite match up with our observation, but I may have, if a person has lower cognitive ability to start with, in a sense, they maybe not declining more rapidly, but they have, less skills to decline from. And so that the drop, all at the same rate, it may be that it seems quicker because they have less far to fall, if you will. But anyway, the study came out and said rate of decline does not seem to vary based on initial cognitive level. But these sudden changes can occur, and they can be for all sorts of reasons. Some of them which we can do, we can change. They can be a stroke, and typically, or most commonly, these are strokes. Not atherosclerotic strokes, not where you get a clot in the artery in the neck. These would more commonly be either embolic strokes, and embolic strokes occur typically in people with Down syndrome, most commonly in people that had congenital heart disease, who either develop some rhythms that lend to clotting inside the heart, or they have a part of the heart that doesn't beat normally, and that lends itself to clots developing inside the heart. And so sometimes those clots will break off and go to the brain. And there was actually a study done in Australia several years ago that on hospitalized patients, and they found that these embolic strokes were more common in people with Down syndrome, and again thought to be related to embolic strokes from the heart. And so again, that's an issue. But the other kind of stroke that happens apparently more commonly in people with Down syndrome are these little strokes that occur related to the amyloid that's part of the Alzheimer's. Builds up in the brain. It actually damages little small blood vessels, these tiny little blood vessels. And then these little blood vessels leak, and they leak blood, and that causes a stroke-like situation. So that seems to be an issue that is more common in people with Down syndrome who develop Alzheimer's disease than in other people who develop Alzheimer's disease. But it can be things like infection, a bladder infection, a pneumonia. So that can make people appear to have lose skills more rapidly. Depression is not uncommon in people with Down syndrome who develop Alzheimer's. Really, any of us that develop Alzheimer's, depression is an issue and can certainly make us much less functional. A new onset of change in metabolic condition like diabetes. Dehydration is a big one. A lot of people with Down syndrome aren't big water drinkers to start with, and then when they develop Alzheimer's disease, they even drink less fluids. And so we really have to sort of keep after them to make sure they're drinking enough, or they'll get dehydrated, and then that makes people significantly more confused. Inadequate sleep, a roommate that's keeping them awake, can really be very problematic for someone that's developing Alzheimer's disease. It can really wreak havoc on their thinking and their cognition. And then pain. Again, I mentioned that pain's kind of tricky in folks with Down syndrome. We have an article on pain in our research library. I encourage you to take a look at. But again, people with Down syndrome experience in pain. In fact, in some studies, they experience pain more than the rest of us. And as they develop neurological changes, particularly with Alzheimer's, the amount of pain they perceive actually maybe even go up more. And so that, certainly for any of us, if we're uncomfortable, we don't function as well. And so that can certainly contribute to Alzheimer's disease as well, and this rapid decline sometimes. And then certainly environmental factors. Too loud, too soft, too hot, too cold, too much light, too dark. All these things could cause people to be more confused. Caregivers with the best intention, maybe trying to guide the individual, and they may be real frustrated. And so the person may say, for example, the sky is pink with purple polka dots today. doesn't really matter that it's not. And to argue with the individual is just going to frustrate them likely, and then cause them to be upset, and actually may cause them to seem more confused. Similarly, it's recommended, for example, I go see an individual with Down syndrome and Alzheimer's disease, and rather than say, do you remember me, or do you remember my name, I'll just say, hi, I'm Dr. Chicoine, because kind of quizzing them like that, if they don't remember, that can be frustrating and upsetting to them. So again, looking at things that we can potentially doing that might make the individual more confused. But as far as other treatments, on the left there, the associated symptoms. So we talked about depression and anxiety and behavior change and sleep challenges and pain and seizures. We want to address all of those as best as we can. And we want to continue to look to see, are these things part of the decline? Or have these things come about after they've declined and it's contributing to further decline? So we really want to look at those things. And so again, we want to look at, are there things we can do with diet or exercise to really help people feel better? But also, are there medications perhaps that are needed? And depending on what the symptom is and what the person's overall status is, that would help us choose the medication. So if their person is depressed but having trouble and also having trouble falling to sleep, there are antidepressants that would be better for that. If the individual is having more pain, there are certain medications for that, et cetera. So lots of things that we can look at. And then some of the seizure if the person is getting upset easily or getting aggressive, sometimes some of the seizure medications also help that. So that might be, if they develop seizures, maybe how we help choose the seizure medication. And conversely, there's a seizure medication that can cause people to get more agitated or more upset. So again, if that's already a problem, that's probably not the choice that we want to pick. So again, there are lots of different ways we can approach that to try to help optimize individual symptoms and how they feel. In the right there, the medication is more specifically for Alzheimer's disease. And so the studies at this point have not demonstrated that the medications are beneficial for people with Down syndrome for Alzheimer's disease, into the data that we have at this point. And so the medications in the cholinesterase inhibitors, things like donepezil, Aricept, and those medications really, and then also in the NMDA receptor antagonist memantine, really there's no clear benefit in the studies, and that would be our experience as well. And then the newer medications, these amyloid beta therapies, the ones that are actually addressing the amyloid, those medications, unfortunately, as someone quoted, I was at a presentation a while back, and someone quoted that there's 17,000 people were studied with these medications, and none of them had Down syndrome. And so we really don't know how these medications work in people with Down syndrome at this point. Will they work better, worse, or one of the concerns with these medications is that one of the complications is, as I mentioned, those little bleeding, those little strokes that occur from the injured little blood vessels. That problem is more common in people with Down syndrome, and then these medications actually, that's a complication of those as well. So will people with Down syndrome have more of those little hemorrhages, and will the risk from that actually exceed any benefit, or will actually those little strokes actually negate any of the benefit we get from medications? I'm not saying it will, we just don't have the answer to that. So there's some studies really gearing up here to really look at that. And we actually hope to be part of one of those studies with one of those medications for folks with Down syndrome. So I mentioned before the MRI, certainly if you're going to get these medications, an MRI is a key before and during the treatment, again, to look for these hemorrhages, PET scans to help look for the amyloid in the brain, lumbar puncture to look for findings that are consistent with Alzheimer's disease. And then certainly a lot of work being done right now on blood biomarkers, other tests. Right now, Alzheimer's disease in a lot of ways is a clinical diagnosis, along with, based on history and physical and the neuropsych testing, and then ruling out these other causes, as I mentioned. But going forward, will there be, it's anticipated there will be much more objective measures. Blood marker A goes up, blood marker B goes down. and with Alzheimer's disease, and if you treat it, A doesn't go up and B doesn't go down. So ultimately, we're really looking that hopefully we'll see more objective measures, if you will, for Alzheimer's disease going forward, and that's coming, but doesn't seem to be here yet. But again, a lot of work being done on this in not only in the rest of the population, but in people with Down syndrome as well. But at the moment, we're sort of with left with the concept in medicine of do no harm. We really want to try to minimize risk and optimize benefit, and we just don't have the data that tells us that how we're using these medications does those things. And again, I mentioned the amyloid angiopathy, these little bleeding that occurs in these vessels, and again, we don't have the answer with these medications, their effect of that in people with Down syndrome. And then we talked about the stroke. So really starting to get to the point where we're really going to start to look at some of these medications in these studies, and it's happening hopefully sooner than later. But a number of studies, we're just in the process of joining this ACTCDS, which is an Alzheimer's Clinical Trials Consortium, and we just got accepted into the TRCDS, which is the Trial Ready Cohort. So really, and then there's a study going on called the ABATE study, which is actually looking at a vaccine or an immunization against Alzheimer's disease. And ABCDS is another organization that's looking at some of these things. There's actually sort of three big studies that looking at right now. The ABATE I mentioned with the vaccine, the HERO study, which is medication is actually injected in the through a spinal tap. They inject the medication into the cerebral spinal fluid. And then the Aladdin trial is the one that we're hoping to be part of, which is, again, looking at one of these medications that reduces the amyloid. So hopefully in the coming years, we'll have more information. So it's really been amazing, just in the last several years. For years, it's coming. As far as new opportunities and new studies, and now they're really here, which is really exciting, and hopefully we'll have some good answers in the next several years. So that's in the next few minutes. Let's shift gears and let's now we'll assume that the individual has Alzheimer's disease, and how do we support that individual, and what can we do for them in daily life? And that's Dr. Frank, our occupational therapist, with one of our patients. So first thing, I think the first strategy really is I think in some ways the most important, and that's focus on what the person can do and what they enjoy. So we really want to help them enjoy the days that they have, enjoy what they're capable of doing, rather than continue to try to push them to do new things or things beyond their skill level. So what we have to assess what can they do and what do they enjoy, and how do we help them to do those things. And we also want to encourage safe social interactions. And I mean by that is situations that seem very stressful can, again, cause a person to, feel more challenged and more upset and actually decline more rapidly. So we want to encourage situations where they feel safe and where they enjoy. Communication is so important. So, again, if I'm seeing somebody and they're sitting, I want to, sit in a chair as well, and I want to get down to their eye-to-eye level and speak to them eye-to-eye. Speak calmly with a slow pace, which, as you're hearing me, I have to really work at because I tend to talk too fast. But speak slowly, calmly with a slow pace. Provide simple instructions, and often using hand gestures or a visual along with the verbal communication can be very important. Limit choices. A lot of people begin to have difficulty making choices. And so families will describe, in the morning, we put 2 outfits in the closet or on the bed or whatever, so that they just have 2 to choose from. And as the disease progresses, sometimes they'll just put 1 outfit. And so they have a choice, but it's only 1 choice. And so that really helps reduce people getting anxious or upset about trying to make a decision. Minimize background noise, which sometimes can be very challenging for the individual with regards to not only upsetting them, but also with regards to helping them, making it more difficult for them to hear or to understand what you're saying. And avoid arguing. Again, we went back to the sky with pink and purple polka dots. Years ago, a social worker I was presenting with said, if if there's an argument between you and a person with an Alzheimer's disease, there's only one person at fault, and it's not the person with Alzheimer's disease. So we really want to, if it's a non safety issue, again, if they want to, play baseball on the street or play cricket, I guess would be, or soccer, whatever, or football, rugby on the street. Obviously, that's an issue that has to be addressed. But again, if they think the sky is pink with purple polka dots, it really doesn't matter in a sense, and just sort of letting that one go. And then again, as I mentioned, avoiding asking if they remember, rather than just introduce yourself, rather than asking them to tell you your name. And then there's a lot of different strategies, sensory strategies, visuals, home safety and adaptive equipment, handrails, ramps, reflective tape, etc. This is a delightful booklet, a guide put out by Down Syndrome Scotland. It's available free on their website. I encourage you to take a look at it. Really some great suggestions on just helping people in day-to-day life to get through more comfortably. So a couple examples. One is they show an example of mashed potatoes, white mashed potatoes on a white plate, and how that can be visually confusing to the individual. So put the white mashed potatoes on a yellow plate or a blue plate, whatever, and so that there's the contrast. Toilet seats, so this toilet seat being a different color than the bowl can be very helpful. So little things like that. Years ago, we were talking about this, and we said, we don't even have this in the bathrooms in our office. So we put a sign on the bathrooms that indicates it's the bathroom on the bathroom door, just to help people find where they're going. If people in their home, putting their picture on their door, next to their door, just to help remind them that that's their room, can be really helpful. So lots of different little things like that. I encourage you to take a look at that. Really great suggestions in that booklet. And then one more thing I want to talk about is end of life discussions, and certainly as the disease progresses, and at this point we unfortunately don't have a cure for Alzheimer's, and so ultimately it will be, it is a terminal illness in a sense. And so how do we figure out what the individual wants, and so how do we have these discussions? So that's a nice end of life guidebook, again, by the National Down Syndrome Society, that's available free on their website. But it can be challenging to have these discussions, because a lot of people with Down syndrome have a distorted perception of time, and so you're talking about months or years down the road, and they're concerned that you're talking about tomorrow, and so that can be confusing. A lot of people with Down syndrome tend to perseverate, or really kind of focus on something, and so sometimes I remember years ago, a family, the parents bought to an age where they were making their plans for the future, and filling out their will, et cetera, and so they went ahead and bought their cemetery plots, and so they bought 4 plots. You could buy 2 or 4, and so they bought 4 just so that their son would ultimately be buried near them, next to them. And then he heard about this, and he was absolutely convinced that he had developed a terminal illness that they were declining to tell him about. So he really perseverated about this for years. It took a long time to help him. He really became depressed and became something we really had to work on to help him get through that. So again, that perseveration can make it a challenge. The burden of treatment may feel different for everyone. So you really got to, what does this mean, for them? What are the implications for the different treatments with regards to where they live, or how they manage their day, or what they would like? Those are all things we really have to take a look at. And then the other issue is that there's a large heterogeneity of level of intellectual disability at the baseline in people with Down syndrome. So how do you, what maybe makes sense for somebody with a ability to read and really comprehend verbal instructions very well, versus someone who does not have those skills. So really, that makes it really have to sort through that. And then again, what is their emotional capacity? Some people with Down syndrome will have a higher cognitive ability than their emotional capacity. And so if we start talking about this, will this have a real negative impact on their mood and how they feel? And then again, obviously, the dementia into the whole category, into the whole picture, and it can make it that much more difficult for the person to really participate in the conversation. But people can, at least in some situations, We had a woman a while back, a few years ago, 2 or 3 years ago. She was dying of something else, and trying to talk to her about this. And I didn't really think I was getting through, and that she really wasn't understanding. But one day she's at home with her sister, and she said to her sister, heaven's going to be getting crowded. And her sister said, what? And she goes, well, mom is there, and dad is there, and Uncle Joe, and et cetera there. And when I get there, um, uh, it'll be more crowded. And so it was clear that she understood, and she was ready. And so that really helped us to try to, as we were trying to make end of life decisions for her, it really was good to know that she had some sense of that. Um, One of the other issues in families and folks with Down syndrome, many families have had to struggle with the health system, throughout the life of the individual with Down syndrome, feeling like the health system just does not uh, treat the individual with Down syndrome with respect and dignity, and so really feels very abandoned by the healthcare system. And so when you start to talk about end of life discussions, perhaps do not resuscitate, or would the person go on a ventilator if they develop respiratory distress from pneumonia, et cetera. Sometimes they just feel like this is just the health system abandoning them one more time. And so really it's not an issue of abandoning the individual. It's an issue of giving the care that is going to provide the individual with the best life, the best quality of life, and makes the most sense for where they are in the course of their disease. So again, that's one more hurdle. When I talk to families, we really have to make sure that we're not helping making the family feel that they're being abandoned again. But there's a number of booklets and pamphlets and whatnot that talking the end of life, and the Jenny's Diary booklet. The one on the right is actually a textbook, lengthy. It's written by an author there from Australia. A good book. It's a long one, so that may not be what you're looking for. Not cheap either, but it's an excellent resource. And then one other thing is that how other people with an intellectual disability or Down syndrome are affected when there's someone around them with Down syndrome. And certainly, I think the first thing to consider is it does impact some individuals. This can be hard to have your friends or your coworkers develop, people you live with develop these changes, and it can cause fear and anxiety, and can cause resentment. He can no longer, he's no longer doing the chores, and I still have to do the chores, kind of thing. But on the other hand, it can bring out the best. It can really bring out, we've seen some individuals really become delightful caregivers, or, assisting with the individual with Down syndrome who's developed Alzheimer's disease. But I think that the thing to think about, that it often gets overlooked that the people are being affected. And so, we don't even tend to think about that. And so that's really important to think about. And then in the last few minutes, I want to just talk about healthy aging. And so, really we want to, it includes optimizing physical, mental, and social health with health promotion and medical care, and certainly an interaction with healthy eating, physical activity, recreational activity, sleep, all stress management. And I'm going to kind of jump through these quickly just to make sure we have some time for questions. But again, healthy eating, there's no one diet that's clearly been shown to prevent Alzheimer's disease. But certainly in the non-Down syndrome population, there are some data. Things like the DASH diet, or the Mediterranean diet, or the MIND diet, which combines the Mediterranean and the DASH diets, do seem to potentially delay or reduce the risk of developing Alzheimer's disease in the non-Down syndrome population. Studies have not been repeated in people with Down syndrome yet, but really no reason to suspect that those won't have some benefit in people with Down syndrome as well. Again, just generally reducing processed foods, adding green leafy vegetables, making food swaps, grilled instead of fried, cauliflower instead of regular pizza crust. Again, nothing that's earth-shattering or probably not things you've heard before. But again, there's the potential that this has impact on Alzheimer's disease as well as other health conditions. We really encourage involving the person in planning, participating in the shopping and meal preparation. A lot of people with Down syndrome can learn to look at food labels. They can use apps and visuals, using portion control products like portion control plates. Discuss which parts of the meals to have seconds, like fruits and vegetables. So really, a lot of people with Down syndrome can really participate in this and become very knowledgeable about ways that they can improve their diet. Hydration, very important, as I mentioned before. A lot of people with Down syndrome do not drink enough fluids, and so they might develop dizziness or unsteadiness because they're dehydrated. Again, fatigue, and it can cause more confusion. In our experience, a lot of people with Down syndrome are not big water drinkers, so we do try to encourage eliminating the pop and the soda, and then just look for other ways to get the water in: seltzer water or sparkling water, flavored water with fruit, the infusers. All sorts of different ways that we can try to get more water, like the rest of us, trying to drink enough fluids. And then physical activity. Certainly in the non-Down syndrome population, there are some good data coming out about the impact of the regular physical activity can have on delaying or preventing Alzheimer's disease. And so really we want to make sure we're looking at that in people with Down syndrome throughout their life. General recommendation is 30 minutes, 5 or more days a week. Again, doesn't have to be all in one 30-minute in session. It can be 3 10-minute sessions. But again, there's so many benefits for health, including the potential that this may prevent or delay Alzheimer's disease. It can be a variety. We encourage a variety of activities: aerobic, strength, stretching, balance. And again, as I mentioned before, the preferences may change with age. Make it fun. Music or watching TV can make it more fun for individuals. Be active with others. Turn it into a game. Build it into the schedule, under the calendar. Sleep, very important. Sleep apnea is significantly more common in people with Down syndrome. We want to make sure we're addressing that, because that's clearly associated with Alzheimer's disease. But just general poor sleep has serious negative impacts on the brain. And so really working on healthier sleep hygiene. We have a lot of information on our website about sleep hygiene, and helping people develop good sleep patterns. Like good bedtime routines. Certainly review the current medications if they might be interrupting with sleep. Consider there's a variety of natural products that can help with sleep. And then again, talk with healthcare provider about prescription medications if appropriate. And then we certainly, as I mentioned with the hearing before, we know that mental stimulation is very important, and social interaction, all very important. Again, paid or volunteer work, games, puzzles, activities, all things to keep our brain stimulated. But a study came out a year or two ago, maybe not quite that long ago, in people with Down syndrome. The more complicated the job that they're involved in, the more brain activity it took to do their job. Really did seem to have an impact on delaying or keeping their cognition higher for longer. And so again, really trying to look at ways we can help individuals with Down syndrome stimulate their brain. And again, similarly with the social engagement, friends, family, housemates, recreation activities, all very important to stimulate the brain. And then mental well-being in general, and oftentimes I talk about high blood pressure being less common in people with Down syndrome, and inevitably somebody will ask, well, is that because people with Down syndrome don't have stress? And the answer to that question is that's clearly not the reason. People with Down syndrome clearly have stress, and we just have to help. They may display it differently. They may have different stressors in their life. They might be paying the mortgage, but they do have issues that they find stressful. And so really working with them on their stress management. And we have a lot of information on our website about stress management. And the two young women there did a delightful video with us for us on tips for dealing with stress. And if you're going to watch any video on our website, I encourage you to take a look at that one. They did such a nice job. I really enjoy that video. So what are the key points here? The life expectancy of people with Down syndrome is about 60. There are similarities and differences in the aging process in adults with and without Down syndrome. Some health conditions are more common in adults with Down syndrome as they age. Some are less common. And there are many lifestyle choices that people with Down syndrome can make to be healthy as they age. And we certainly encourage those throughout the life. And it's never too late to start is the other issue. There's benefit there. So again, that was a whirlwind tour. We have lots of resources. If your health professionals are looking for more information, they consider we do have some folks from Australia for health professionals in our Down syndrome medical interest group. In the membership, we have a speaker series. We have a Project Echo, which can help healthcare providers to present a case anonymously that or de-identified, if you will, to get some help from a panel of experts to understand, what the needs of their patient are. And I understand there's a Down syndrome medical interest group being developed in Australia, I think, from what I understand. Again, our website has a lot of information, our resource library. We have an email list, Facebook page, Instagram. You're certainly welcome to all that's free information. And then we have lots of articles on the topics we talked about today that are available on our website. And we have a number of webinars you might be interested in to take a look at. And the resource topics. And then there's, if you're interested in looking at some of the primary literature, it's there as well. And I'm going to stop and open it up for questions.